In Vietnam, it's amazing how many people have osteoarthritis, and they're not particularly obese population. They don't have a massive obesity problem like you have in the United States, but there's still a lot of osteoarthritis. So another aspect, the numbers are not underestimate. I would estimate there's probably more than 750 million people right now. And that number is definitely going to be more than 1 billion by 2050. It's estimated by 2050 it could be as much as 1.25 billion people with osteoarthritis.
Great. Well, it's a real pleasure to have Ali Mobasheri on the show today. Welcome.
Thank you. Good morning, everyone. Good afternoon, wherever you are.
Yes, it's so great. You're in Switzerland. I'm in Portugal now. And the listeners, really, you're everywhere, girls, mostly girls. But I want to give a little overview. We met at the European Menopause and Andropause Society conference in Valencia just, I guess, a month ago. And
Correct.
it was amazing. And I was blown away with your presentation on osteoarthritis. When I saw that on the schedule, I'm like, I am going. And everyone who's listened to this show knows that I had two hip replacements because of osteoarthritis at 54, which has been kind of crazy. So we're going to dive into this topic. But what really blew my mind was you talk so much about the connection with menopause and osteoarthritis and the loss of our hormones, and but you also said this is not a wear and tear disease. And that I was like, okay, I've only heard one other person say that. And I want to hear more about it. With your background, you're just like the perfect person to ask about this. So whenever I speak, people interview me on their podcasts about osteoarthritis and share the story. It seems most everybody gets mixed up with just like arthritis or rheumatoid arthritis. People think it's osteoporosis. These are all very different. So let's give it a little overview. What is osteoarthritis? And just so the listeners understand the differences.
Thank you. Well, the definition is originally a Greek word, and this was pointed out to me by one of the Greek doctors after my lecture in Valencia. In my lecture, I was talking about the itis part of osteoarthritis, emphasizing the inflammatory component of it. And I mentioned that in Latin, most of the Latin derived languages may be referring to it as osteoarthrosis, which doesn't imply an inflammatory disease. So she quickly stepped in and said, let me give you a very important lesson. This is an important distinction. We Greeks came up with the terminology first. The original word osteo and arthritis are originating from the Greek language. But nevertheless, if you look at European languages, French, Italian, German, in many of these languages, when the terminology is being described in that local language, it implies that it's not inflammatory. So let's start there. For decades, we thought that it was simply a wear and tear disease, and that myth needs to be busted. It's outdated, it's unhelpful, it's confusing, the regulators don't like it, and of course, the patients get confused. So we now understand osteoarthritis as a very complex, heterogeneous, mechano-inflammatory disease. So it's mechanical and it's inflammatory. It involves inflammation, it involves metabolic changes, and there's even immune dysregulation involved. So decades ago, say for example 30 years ago, we never described it in that way. And of course, we never highlighted the sex differences. We now know that women are disproportionately affected by osteoarthritis, and that's where you and I met and discussed. This wasn't discussed in the early days when I started working in this area. We treated everybody the same, men and women, but it's clearly an important issue. The sex differences need to be defined and sorted out. And then, of course, hormone-related changes in midlife and post-menopause and andropause. We know that this area is also understudied because there have been a number of studies looking at association between pain and symptomatic progression in postmenopausal women, but not nearly enough. So that's another area that needs to be addressed. And of course, as far as patients are concerned, the language that's been used to describe osteoarthritis has been inappropriate and negative. You go to your GP, you go to your primary healthcare provider and you get a diagnosis, say, for example, in your early 40s, and very often the GP says, "Oh, it's osteoarthritis, it's a wear and tear disease. There's nothing I can do for you. We'll send you to radiography, we get some x-rays done, but really you've just got to take painkillers when the symptoms get worse." And every now and then a good GP might say a few words about physical activity and weight management, but even those conversations often don't come up in a typical 3 to 5 minute consultation. So then after that, the patient goes back to the GP to talk about their symptoms and if things are getting worse, if there's flares. Again, that's where we need to have a bigger impact on the relationship and the discussion between the GP and the patient to facilitate this more helpful, more constructive dialogue about what the disease is, highlighting that it's not as bad as those early consultations may make out. It's manageable, and there are many ways to educate the patients to self-manage and improve their symptoms and long-term outcomes.
So what I explain to people who, when they hear them say, "Oh, you mean osteoporosis?" No, osteoporosis. This is the bone density, and I've tested my bones; they're actually really strong, but it's the joints, it's the cartilage, I guess, wear down. And you don't have range of motion anymore. You can't open your legs. I couldn't get on a bike. I couldn't sit down. It couldn't. And then it's this swell. Some people feel swelling. Some people can't sleep at night. It's a journey. And so you're not really sure why, but you see that if the range of motion gets tighter and tighter and tighter, and it gets to a point where you just can't really walk anymore. And certainly forget it's the daily activities of living. For me personally, this is where it just got so bad. But up until then, for years, I was given the word osteoarthrose in French and in Spanish. I'm like, well, what's that? I'm like, is this the same thing? I don't really know. I don't really care. It wasn't that bad. I just continue with my rehab exercises and try to manage pain as much as I can. So if anybody out there listening, it's definitely, this is very different than a bone density problem. It's much more the joints. And I had, of course, in my hips, but people I think it's more common in the knees. Is that correct?
Absolutely, yeah. The major global burden is the knee. That's the highest number of cases in the world. And then, of course, it's joints such as the hips and increasing the hands. And then smaller joints, the ankles, shoulder can also be affected too. But the knee is the main global burden.
Yeah.
And the point you made about osteoporosis, that needs to be clearly defined for your listeners. Osteoporosis is where bone mineral density is lost and bones become lighter and more brittle. And one of the consequences of those osteoporotic changes is femoral fractures in the hip, right? So as you get older, the risk of developing fractures either spontaneously or through a fall. You might fall in the bath, or you might fall in the street, or even during exercise and physical activity. Those falls will result in a femoral neck fracture so that your femur, the top of the femur, breaks off. And that's basically osteoporosis, this disease where the bone density gets lighter and the bone becomes more brittle. It is obviously in older people, there's an overlap between osteoarthritis and osteoporosis, meaning many people have both conditions and also muscle loss, which we call sarcopenia. And increasingly in the modern world where there's so much obesity and overweight around, there's also sarcopenic obesity, meaning that there's obesity that's driving the loss of muscle. So osteoporosis is a different disease, but what is very interesting is that the overlap between them at the tissue level is in the bone, in the subchondral bone. So osteoporosis doesn't involve the cartilage and the wearing down and the gradual loss and deterioration of the articular cartilage. But clearly, that's where the subchondral bone, the bone beneath the articular cartilage, is involved in both diseases. And we are starting to think that there are really important overlaps and mechanistic links between them. So different diseases, distinct mechanisms. You use different drugs to treat them. In fact, some of the osteoporotic drugs, zoledronate, for example, some of these osteoporotic drugs have also been tried in osteoarthritis patients in clinical trials, but the majority of them have not had any impact on the pain and the functional decline in osteoarthritis. So even though bone, cartilage, synovium, and all the joint tissue compartments are involved in osteoarthritis, the bony compartment doesn't seem to be producing any really promising drug candidates so we can treat both diseases. So unfortunately, we don't have a magic bullet to treat both osteoporosis and osteoarthritis.
Yeah, not yet.
Not
Yeah,
yet, but it's work in progress.
exactly. And we're going to talk a little bit about some of those options and drugs a bit later, but I wanted to talk a little bit about the prevalence. And correct me if I'm wrong, because you know the stats much better than me, but I learned that there's about 595 million people worldwide who are affected with osteoarthritis, again, any kind of osteoarthritis, and that's 7.6% of the global population. This is a 2020 statistic, so I don't know, maybe it's even higher. Is this accurate?
It's higher because those statistics came from areas of the world where there are good healthcare systems and systems for monitoring the epidemiological impact of the disease. So we've got accurate information from more or less from North America, from Europe, but then, if you think about it, not much from Africa, South and Central Africa. We don't have enough information about OA prevalence in some of the South American countries, some of the Caribbean countries, and also Asia. Now, there are parts of Asia where there's really good up-to-date information, but there are countries where we are actually surprised by the statistics. I'll give you one example, and that's Vietnam. In Vietnam, it's amazing how many people have osteoarthritis, and they're not particularly obese population. They don't have a massive obesity problem like you have in the United States, but there's still a lot of osteoarthritis. So another aspect, the numbers are not underestimate. I would estimate there's probably more than 750 million people right now. And that number is definitely going to be more than 1 billion by 2050. It's estimated by 2050 it could be as much as 1.25 billion people with osteoarthritis. And of course, the population is continuing to expand in some parts of the world and shrink in others, which means there's going to be more elderly populations in some of the very advanced economies of the world. United States, Northern European countries, Japan, South Korea, you name it. Those countries where birth rates are declining and aging population is expanding. What are you going to get in those populations? You're going to see more of the osteoarthritis and also more of the low back pain. And low back pain, there is a form of spine osteoarthritis which overlaps with low back pain because low back pain is very complex, so many different syndromes under one umbrella of low back pain, but a component of that is also spine osteoarthritis. So it's not just in the knees, it's not just in the hips, it's also in the hands, it's also in the low back, it's also in the spine. So if you add all of those numbers together, you're going to have even more than 750 million people.
That's insane. I was really curious about the statistics in Asia because when I was spending a lot of time in Asia with osteoarthritis, getting so many massages, and you see, oh, wow, these older women can crawl around the bed and move. It's like nobody here's got osteoarthritis, but in fact, I'm very wrong. And when I was researching, what can I do? If you Google this, you will find lose weight. This is not my problem. I'm very athletic, very lean. When I stood up on that microphone in that conference and said, hey, what can I do? You looked at me, you were like, well, if you were overweight, I would have said one of these things. You'd probably have to lose some weight. But that was very frustrating during my search for answers and what I could do. But it does show as well when you think about the knees, the hips, and maybe the spine. Yeah, weight bearing pressure on the joints. I can see why that happens. But I'm really curious, like when you said, wow, there's in Asia, people are generally lean. So why are they getting osteoarthritis, right? This is a question. I don't know if you have answers to that, but do you know why?
Well, one of the biggest questions in the field is osteoarthritis truly inevitable with age because there's a lot of really exciting work going on senescence and targeting of senescence and aging in joint tissues through the use of xenomorphic and xenotherapeutic agents, which can be like drugs, but many of them are actually natural compounds from foods.
I understand it as senescent cells, those quote unquote zombie cells that are active. They're kind of gone rogue, the grumpy old men cells that they causing a lot of havoc is what some people way to describe it. And they're kind of useless. So you want to be able to get rid of those cells. They're not sure if they're going to die or stick around and cause some inflammation and problems. Is that correct?
Well, what we used to think is that maybe killing them would be the solution. But, some of the joint tissues, especially articular cartilage, already has very few cells in it. The cellularity of articular cartilage of the knee and the hip in me and you, in us young people, is about 1%. So imagine if you also had these senescent cells that you wanted to kill with senolytic drugs, then you're actually killing some of the cells that could be responsible for better maintenance of your joint tissues. So, my personal view, and I know some of my colleagues and researchers disagree with me, but my personal view is that it's better to tame the cells and modify their behavior. So, turn these grumpy old men, moany old men, into more compliant and more cooperative agents. Get them to cooperate more and actually not produce these inflammatory mediators. And that's where a lot of the current research is targeted to develop xenomorphic agents, xenotherapeutic agents that can actually modify the behavior of these senescent cells, and not just in the joint, but also systemically. But let's just go back to this concept of aging. We know that age is the number one risk factor for osteoarthritis, which passage of time is not modifiable, right? But the way we age could be modified. So it's all about healthy aging. It's a very, very popular terminology now. The World Health Organization is using it, and some people have jumped on the bandwagon and come up with their own very odd terminologies like positive aging and terminologies that may not be as widely used or adopted by the regulatory agencies, by the World Health Organizations. Basically, what we're talking about right now is healthy aging. So, aging is the number one risk factor. Second risk factor is obesity. That's where it's modifiable. But the third one is joint injuries. Actually, the third one is sex. So, the female sex already is a bigger risk factor for development of osteoarthritis. And after that is previous incidence of joint injuries. So that's where you can actually have an impact by reducing obesity and manage the risk of activity induced, say, for example, in amateur or professional athletes, joint damage, or in an occupational setting, reduce the risks for people who are doing repetitive motions that could predispose them to getting knee or spine or even elbow osteoarthritis. There are, for example, construction workers. That's a really good example. So there are ways to mitigate those things. But lifestyle overall, lifestyle is a really powerful modifier. And when you stood up and asked me that question, look at me, I've had hip replacements and I'm lean and I've been active all my life. And my response to you was there's probably a genetic component in there that we currently haven't got a good handle on. But we know that genes are really important. But what's even more important is the interaction between your genes and your diet and your environment, meaning the air that you breathe, the environment in which you live, and also the food that you eat. That's what's able to modify your microbiome. So it's a whole new horizon in osteoarthritis research is looking at the interaction between diet and the microbiome and diet and combined with physical activity and exercise and how that might modify the microbiome. The bacteria that live in our guts can weigh as much as 500 grams, as much as 750 grams, and in bigger people, they will weigh more because they've got more intestines to carry. And these bacteria produce not just toxins, they also produce drugs. They produce the drugs that can influence our well-being: 5-hydroxytryptamine, serotonin, mood influencing drugs. So that's one of the other reasons that the hypothesis is that people with osteoarthritis have lower mood and they have more anxiety. And if they have a very painful osteoarthritis. They're also catastrophizing about their condition. They have a very negative outlook. Some of that could be actually related to changes in the microbiome. And that's what we're trying to understand. What are the changes in the microbiome of a person who's living this with this disease and maybe with a couple of other comorbidities such as cardiovascular disease or diabetes that has an impact on their microbiome. And if this person is also eating a diet which is rich in refined sugars and refined flour, low in fiber, low in colorful fruits and vegetables, and not the right type of protein. And overall, the diet is not balanced, and that creates an inflammatory gut microenvironment. It actually promotes the bad bacteria in the gut to get more active and start producing these sort of endogenous nasty drugs that could influence by getting across the gut barrier, they could influence not just the joints, but also the spine, and even have impact on anxiety and mood as well. So we need to think much further and much broader about this concept, not just focus on the knee that's painful. We need to think about the holistic approach. And that's where patients can be so much more in control of their condition if they consider their lifestyle, if they're constantly thinking about what they're eating, how much they're exercising, and what kind of sugary drinks they're consuming. Are they walking enough? What is their posture like? You and I are sitting in front of our computers many hours a day. We need to take regular breaks and we need to make sure that the posture that we have is correct for the work that we do, extensive work with visual display units. So it becomes a holistic approach. It's not just pop a pill and hope that it takes your symptoms away. You need to rethink the whole paradigm, and much more control can be gained by patients by considering the lifestyle factors.
Mm. Super interesting when you talk about the gut microbiome, and this may be tying into your research in immunology and how, because we know the immune system and the gut are very closely entwined. And when you said the mood and anxiety, well, serotonin, as I understand, 80 or some people say 90% of serotonin is produced in the gut. So the gut microbiome is, again, field, it seems this it's just being scratched the surface of the research, but tell us a little bit more about the immunology, and does this, someone who has, say, autoimmune disease, are they more predisposed to osteoarthritis?
Definitely. So let's start there. I think if you have an autoimmune disease, if you have another type of rheumatic disease where there's a greater immune involvement, your risk of developing osteoarthritis is also much greater. Let's not forget that osteoarthritis affects, as you said, greater than 7% of the global population. In some of the more aging populations, up to 30% in some of the countries where birth rate has declined and the aging population has expanded. And in those populations, there are very significant immunometabolic changes. Let me just define that for you. Immunometabolism is the intersection between metabolism and immunology. And in the recent years, it's become really clear it's a crucially important thing for understanding aging, metabolic changes, and osteoarthritis and low back pain, because immunometabolic changes happen not just in the joint, not just in the spine, but also in all the body systems. We're talking about the cardiovascular system, the liver, many of the inflammatory molecules and many of the inflammatory biomarkers come from the liver, and the liver's responding to the diet and the alcohol that we consume and so on. And the result is inflammation. It's not chronic, very heavy inflammation that you would see in rheumatoid arthritis or psoriatic arthritis or ankylosing spondylitis. In osteoarthritis, the inflammation is more, if you like, low grade. It means it's constantly there, it's persistent, but the grade is not as intense as rheumatoid arthritis.
Mhm.
And so, if you imagine you've got this low grade inflammation and this background inflammation, some of which is exacerbated by the gut and the microbiome and the obesity. Over a period of 20 to 30 years, that can have quite an impact on your musculoskeletal system. And of course, we now think that obesity is a contributor to that, not just through the excess weight on the joints, but because the adipose tissue, the extra fat that we carry when we have a high BMI,
Mhm.
that is not just extra weight, but it's also a source of inflammatory and metabolic influencers of health. And so many of the inflammatory molecules that are produced by adipose tissue are the same molecules that break down the articular cartilage. They're the same molecules that are responsible for degradation of the intervertebral disc in the spine. So whether you're thinking about the knee or the hip, you're exposed to these systemic factors. So if you've got cardiovascular disease, if you're obese, if you've got diabetes, they're going to have an impact not just on your liver and pancreas and heart and cardiovascular structures, but also on your musculoskeletal system. So we need to think about a more holistic approach to treating these chronic inflammatory diseases, not separating arthritis, putting it into one category, and then looking at cardiovascular disease in another category. They're all linked to each other. And all patients with osteoarthritis, right, except of course yourself, right, because you're lean and very active, but many patients out there with osteoarthritis also have cardiovascular disease. They also have obesity and overweight. And that, from an epidemiological perspective, is the population we need to treat. If we had another guest on this show, if we had a politician who had to make decisions about healthcare expenditure, the politician would be quite critical of us researchers and clinicians. He or she would say, well, I want to see an impact in the 5 years during which I'm politically active. We have a narrow window of opportunity to actually have an impact on patients and healthcare so that we can get re-elected. That's what it's all about, right? That's what politicians and policymakers think about. So what are the measures you can take to actually show that you can have an impact on the disease in the short term? From an epidemiological perspective, it's almost always weight loss, weight management, and reducing the impact of obesity. And that's why I think we need to think of the obese population and targeting them because they have a more serious disease. Osteoarthritis is a serious disease, but the more serious disease in high BMI obese individuals is obesity. It's not just a condition. The WHO and the international associations dealing with obesity have classified it as a disease. And as far as seriousness is concerned, it is more serious than osteoarthritis. So your osteoarthritis in your hip makes life more difficult for you, creates pain, and impairs your movement. But let's say, for example, the person who has osteoarthritis and is heavily, morbidly obese, they have a more serious condition and that needs to be treated. And as you know, there are many weight loss drugs currently available. And of course, some of these have been shown to have a positive impact on osteoarthritis symptoms. And the most recent study was done by Novo Nordisk on semaglutide, Wegovy. They did a 68-week trial of very heavy target population, people who had BMI of 35 and higher. That's pretty obese. And not only did they lose weight quite significantly by the end of the 68 weeks, but the treatment with semaglutide, Wegovy, significantly reduced their pain and positively improved joint function. Furthermore, it also reduced the dependency of these patients on the painkillers that they were using for their arthritic knees and hips. So by reducing weight, by reducing adiposity, we can have a really positive impact on a broad, set of the population. But for more specific phenotypes, for individuals who may have osteoarthritis in one joint as a result of a previous injury in life or some kind of genetic factor yet to be definitively identified, they may not be obese. So what is the treatment for them? You don't want to give them weight loss drugs because their BMI is normal. So for them, we need to take more targeted approaches for injecting into the joints with anti-inflammatory and anti-catabolic compounds. Let me also make one other point about the global population. BMI doesn't apply to all of us in the same way. So in Caucasian populations, in European, North American, white populations, because of the higher, because of the taller individuals, because of the fact that BMI is very different in white people compared to Asian people, compared to people in Hong Kong and Singapore and Thailand. BMI for them is a much greater risk factor because their stature is lower. They're not so tall. You can't compare a white person's BMI directly to an Asian person. You can't compare an African American person's BMI directly to a white person. And though those are really important factors to consider. So a BMI of 25 in an Asian person would be considered very heavy, would be considered very obese, whereas in a Caucasian population, BMI 24 to 27 would be considered normal. We don't often hear discussion of that, and that's crucially important because we're all different.
Such a good point. And I noticed that too during my time in Hong Kong as well. And I was measuring people on body composition scales as well. And I was like, okay, wait a second. And I also found quite a few people who were lean but had high visceral fat, which is the fat around your organs. And that's the one that's more dangerous. But I'm wondering because the population, obesity is the number one most modifiable risk factor for all diseases of aging, as I understand. So it's like, wow, what we can control so much, which makes sense. It's these weight loss peptides and drugs. It's like, okay, it's not the drug itself, but you're losing the weight, and that's making the huge impact. And maybe there are some mechanisms of action as well that are helping with blood glucose regulation or whatever it is. But besides that, I'm kind of curious then. When I was doing my research and trying to figure out what to do, you'd come across the lose weight thing. But since then, since I've probably the last 2 years, I have five friends, five people I know directly, all women who've had hip replacements. And they're all under the age of 60 and they're all lean and they're all pretty athletic. And I thought, well, wait, there's different populations here. And I was so happy to actually to find the athletic population with osteoarthritis because I felt so alone. I was like, I'm an anomaly. I couldn't figure this out. And people who know me know I'm very healthy and I'm doing everything I possibly can. But what is the prevalence in terms of, is it far outweigh the obese population, the more sedentary population, those risk factors versus the bubble that I'm living in, where it seems every lean woman under the age of 60 is having a hip operation?
I would say you're in a very unique bubble and a much smaller portion of the population, right? So there are many individuals, Caucasians, who are normal BMI or even low BMI, and they may have knee or hip osteoarthritis. Again, so in those individuals, you're unlikely to have those immunometabolic influences. You're unlikely to have the drivers that you would have in a person who is BMI 35 to 40. Completely different types of patients. Let's call them phenotypes. In fact, I'm really working hard to define these terminologies. Clinical phenotype, what the doctor would see when they interview and discuss osteoarthritis with a patient without the use of any technology. Molecular endotype, what pathways, what receptors may be involved, and what might be distinguishing one patient from another in terms of the molecular drivers, the molecular pathogenesis of the disease. And then there's a new terminology which has crept into the osteoarthritis literature. It comes from cystic fibrosis and asthma, and that's theratype, a therapeutic subtype, a subgroup who could be targeted by a drug which has a very, very specific mode of action. So let's just step back for a moment. For the last 30 years, many of the drug companies, many of the large pharmaceutical companies have been thinking, we want to develop a single agent that you take orally that's going to cure osteoarthritis. What folly, what a fantastic fantasy that is. It's never going to happen because now we know you look at the population, you've got so many different subgroups and subtypes. So the idea of developing a single magic bullet to treat the disease is really naive, very outdated. We need to park it, leave it, and move forward with a more heterogeneous and subgroup based personalized view of the disease. So, for example, in this population of 50 plus lean females, I've met many people like yourself. I was on a train from London to Amsterdam to a conference. I was sitting next to a lady who was working on her laptop. We got talking. Turned out she was a professor of linguistics at Amsterdam University, and she'd had a double hip replacement. And she was telling me, I'm lean, I'm active, I'm not obese, I don't have diabetes, and yet she needed the hip replacement because of the shape of her hips. She had femoroacetabular impingement, which also increases the risk of hip osteoarthritis very, very significantly. And so she said to me, I've had double hip replacement. My life is transformed. I feel so much better. I can do all the things that I never could do in the last few years before my hip replacement. I've got a boyfriend who's 15 years younger than me. The sex is amazing, and I am just a happier person. And I was blown away by that. And I thought, well, this is a very unique phenotype. This is a very unique type of person who's really benefited from, and the hip is transformational. People who have hip replacements, their lives completely change. With the knee, it's not the same because the knee is a more complex joint. There are more risks associated with earlier knee arthroplasties in younger people. So if you imagine in the United States right now, many people who are approaching the age of 50 or past the age of 50 who may have cartilage degradation and knee pain symptoms, they're referred to for knee arthroplasty and they get knee arthroplasty at that age. Yet their life expectancy could be another 30 years. Is that knee going to last them 30 years? Probably not. There's probably going to be need for revisions. So what we really need to do is to push, and this is a philosophical and an urgent sort of global sort of epidemiological issue. We need to push back the knee arthroplasty as much as possible. Patients want to keep their own joints for as long as possible, especially the knee. Once you put in a arthroplasty, either it's a partial or a full knee replacement, it actually feels completely different. Talk to anybody who's had a knee replacement compared to somebody who's had a hip replacement. They will have different stories to tell regarding how they feel and the impact that arthroplasty has had on their lives. So we do also need to think about the different joints differently. Knee osteoarthritis is not the same as hip osteoarthritis. It's not the same as hand osteoarthritis.
Yeah, I heard that a lot. I get these same stories. I never you speak to somebody with a hip replacement. It's always positive. Haven't heard a bad one yet. But the knee, yeah, it's not the same story. And so this is why I love the work that you're doing. And it's about, okay, like how can we delay or avoid this surgery, especially if you're not getting the quality of life back? And I'm really curious to know if it's it seems that there are more and more younger people who are affected by osteoarthritis, who I'm thinking under the age of 65. And there's a stat between 1990 and 2021, the number of osteoarthritis cases in this group more than doubled. And this is a growth rate of 116%. Why do you think? Is it the obesity? Is there something else driving this?
Part of it is obesity and diabetes and change in diet and the consumption of ultra processed foods, because we know there's a correlation between overweight, obesity, and consuming softer ultra processed foods and higher fat, low fiber, high sugar, refined flour type diets. So part of it is that. But of course, the other part is the microbiome, as I mentioned at the very beginning of this conversation. And then you've got to think about the genetic risk factors and in the different joints. That's where the different genes come to play because there are specific genetic loci that may increase your risk of developing hip osteoarthritis and knee osteoarthritis. They're not the same in everybody. They're not the same in the general population. So going back to this concept of obesity and treating obesity, it's only going to work in those patients who have very high BMI. For others, we need to have different treatments. And I think we do need to have a public health message about maintaining good weight, remaining physically active, but also about the kind of nutrition, the kind of food. And that's something we haven't talked about in much detail. There's a lot of news about omega-3s and polyphenols, curcumin and green tea and so on, boswellia, boswellic acid. Now, there's mixed evidence for these things. Clearly, you're not going to be able to treat that very high BMI person with very extensive knee damage with nutritional supplementation. But the general population can really benefit from some of these anti-inflammatory nutritional supplementation. Collagens are also becoming very popular, both oral and there's even intra-articular injections of collagen that are being tested, and patients claim to get a lot of benefits from these. So it's really about having that dialogue with your healthcare provider to come up with a personalized, targeted approach for you. But it always starts, all the treatment guidelines that have been published start with non-pharmacological lifestyle therapies. If you
Mhm.
pick up the US and European treatment guidelines from all the major international societies, non-pharmacological treatments come first. Weight loss, weight management, physical activity, mind-body exercises, Tai Chi, physical therapy, massage, going to spas. I'm in Switzerland right now. The Swiss government really knows how lucrative this area of the industry is. And this Swiss model of the spas and the health, if you like, promoting vacation is now picking up in other parts of the world. There are countries like the United Arab Emirates and some of the other Gulf states who are trying to imitate what has happened here in Switzerland. They want to create these health clubs, then they want to create these resorts when people come and it's not just a vacation where you put your feet up and enjoy the sunshine and the pools. You actually have the treatments done, and the treatments are again starting with non-pharmacological. You don't go to these places to have drugs, you go to have the experience. It could be mineral spring spas, it could be physical therapy, massages. These things are all good. And of course, let's not forget the Romans introduced us to these concepts. So we have got to give kudos to the Romans for starting this concept of the spa. And there are several European countries that actually send osteoarthritis patients to this kind of treatment, and Spain and France are probably the most notable ones, as you know, but it doesn't work for everybody. So for those people who have more extreme symptoms, you've got to have a more targeted treatment. But I think nutrition is really important, and supplements clearly will work for some people. They don't work for everybody, and that's why it needs to be personalized. And we have a lot more work to do for making this area more targeted to those phenotypes that I mentioned, and making sure that we can look at real world evidence, because you compare a clinical trial and you may see that a particular type of supplement or herbal mixture or a herbal pure form of a compound may not show very promising results in a double-blind, placebo-controlled clinical trial, right? Because it's a trial and it has to be blinded. But if you receive that treatment in a real-world context by a caring doctor and an allied health professional, a physical therapist who may also give nutritional advice, it's very different to what happens in a clinical trial context. You're also benefiting, if they're well trained and if they have very good communication skills, you also benefit from this enormous placebo boosting effect that consultation has. And they also have another capability, which is negating the negative aspects, the fears and the anxieties that patients have. So that's what I would call countering the nocebo effect. So you might go in to speak to your doctor about your pain and physical dysfunction, and if he gives you negative messages with negative language, you're going to feel worse. And that's called the nocebo effect. So I think the next generation of healthcare professionals need to be trained not to use that kind of negative language, to use a much more positive, more hopeful. Osteoarthritis is not such a serious disease for you. It's an acute problem. We can work together to find the best solution for you, and we're going to make you feel a lot better. That kind of language, that kind of framework is going to be much more positive for a person to then coexist with that condition. And of course, pain comes and goes.
Mhm.
A person who has pain and gets diagnosed with osteoarthritis is currently referred to as a patient for the rest of their life. I've got a problem with that. I think that's very negative. It's really counterproductive. So, if a patient's pain reduces after a number of years, if their symptoms come under control, I don't think it's appropriate to call them patients anymore. We need to refer to them as a person, as a citizen, a person, an individual living with a condition and managing it, right? And doing all the best that they can with the information and education that's available to manage their condition and not be called a patient all the time. But that's a more philosophical discussion. Maybe we can revisit this in the next episode of your podcast.
I would love to go down that lane because I myself had gone through pain reprocessing therapy and trying many, many things. And I just want to go back to the point of the spa. And one thing I think that we didn't cover yet is, and we can talk about the next one, is the impact of stress and the stress hormones. And then, of course, that's affecting the whole body. And so the idea of going to a spa, where I used to live in Ukraine and Russia for many years, and it's been forever that I know that you go to the sanatorium when you are ill or you have some kind of a disease. And that usually means like going to somewhere like Florida, like the Crimea, or it's where there's palm trees and there's the sea. Getting sea and sea air is just so many therapeutics there, but also the fact that you're getting out of your environment of work and stress and you're in this more relaxing state. And that for sure has an impact on the body. So I know it sounds luxurious, but like you said, there's countries who are recognizing the importance of this and people are healing faster. And when you think about forest bathing, how that came out in Japan, it's because they found out when they put their patients in a bamboo forest, they were healing faster. Like this is a whole field, I guess, that we have to learn more about, but also implement in our healthcare system. But again, the cost, I don't know the cost and then how realistic it is, but we should talk about that.
Absolutely. You can't do a clinical trial of putting people in a bamboo forest, okay? You can't coming up with a control population that don't get that treatment becomes a very, very challenging issue. But absolutely, we need to take vacations and we need to take rest. And these spas and resorts certainly can be very helpful to overall well-being and to the symptoms of knee and hip and back pain. But ultimately, I think it's about affordability and cost. If you come from a well-educated, well-off background, your coping mechanisms and your ability to get these treatments that could work for you are much greater. And if you come from a disadvantaged background, from a low socioeconomic context where you might live in poverty or you might live close to poverty and you don't have a good education and you don't have a good understanding of medical and scientific terminology, that person's going to feel much more anxious. They're going to be much more overwhelmed with the diagnosis and living with the disease and with their long-term prognosis and outcomes.
Mhm.
So health inequalities come into this. And in some countries, women are much, much worse off because they're denied education. I'm not going to name those countries, but there are certain parts of the world where women are worse off because they are not allowed to educate themselves. I'm going to mention one example. Look what's happening in Afghanistan. Women are now not allowed to go to school and university. And look at we're going to see some very negative impacts on their health in years to come. And I think this is really important. The economic aspects and the social aspects. And of course, sometimes religion is a major barrier too, and it actually creates poorer outcomes for females.
Yeah. This is, yeah, another topic I really cover. When I was studying gerontology, I remember this one professor I had, he said, the secret to a long, healthy life is you got to have some money, and money and education will take you far because you'll have access to good medical care. And that just blew my mind. I thought, well, okay, this is really unequal. And so perhaps I think he was kind of alluding to one of the better ways to improve people's health outcomes was to educate them and help them make more money, have a stronger economy as well. I want to go back to the piece about what, in terms of risk factors. I remember when I was researching like, why do I have this? I found out that hormones and menopause, the loss of our hormones, can accelerate the progression of osteoarthritis. And that's exactly what I felt. And I would like you to share a little bit more on how that impacts our risk of osteoarthritis.
Great question. That's one of the reasons why I was invited to the European Menopause and Andropause Society conference in Valencia last month to talk about this issue because I think the organizing committee felt that this is an underexplored and poorly discussed topic. And coming from the osteoarthritis research and clinical development community, we know that hormonal status is important. We know that osteoarthritis becomes more painful and results in greater functional decline in postmenopausal women. Women experience more intense and more frequent pain. We know that there are links to sex hormones and to the chromosomes too, but we just haven't been able to identify the mechanistic drivers of these. As you and I discussed in Valencia, not everybody will get hormone replacement therapy, right? So that needs to be personalized. And there are some countries where HRT is not as widely prescribed as you might like. So I'm sure that hormone replacement for both women and men could have good long-term outcomes. We discussed the topic of testosterone and men's osteoarthritis at another meeting in, I think it was in Dubai last October. And one of my colleagues, who's an occupational physician in Australia, simply asked me this question. Okay, we know that HRT is important for women, for bone metabolism, for bone health. And we know that the link to osteoarthritis is really quite tentative. But what about thinking about the men and andropause? What about them? Is there any opportunity for treating them with hormones that can have an impact on their bone and joint health too? Yes, of course there is, but if you have to think about all of these hormonal treatments, they also have side effects. And so it's the finding the magic formula.
Mhm.
It's using an algorithm that can tell you about the risk to benefit ratio. A person may get enormous benefits from HRT, right? And so that person should definitely be given it. But another person, they may have risk of developing a particular type of cancer. That's where the risk to benefit ratio is altered. So we currently don't have a system to establish this in a big population. So I think that's where we need to focus on to understand, again, through the knowledge of genetics and genetic risk factors, what portion of the population might benefit from hormone replacement and which individuals might have a higher risk of developing a comorbidity or a cancer that wasn't intended as part of that hormone replacement. For that, we don't have a very clear answer. And in my field, this area of the sex-related differences is only recently becoming an urgent topic. It's because the European Commission that's funding a lot of the research and some of the large funding agencies are placing greater emphasis on sex-related differences and this issue of post-menopause, post-andropause health, going back to healthy aging. So we don't have a solution right now, but I can summarize by saying that many women who would benefit from HRT are not receiving it.
Mhm.
And so that is a gap that we need to address.
The link that I make between osteoarthritis and the loss of, let's say, estrogen, because estrogen, as I understand, is an anti-inflammatory. It's a lubricant. It hydrates. It helps us build collagen. So I think, well, when you say the prevalence is much greater in women than men, I've kind of thought, well, it seems like, well, yeah, if you've lost all this quote unquote protection or this anti-inflammation, not that that's the only thing, right? There's a lot of things that factor that certainly, well, that I can see a correlation, perhaps. And again, I don't know if there's any research on that proving that, yeah, estrogen, maybe if you, yeah, if you lose it, this is what happens. Or because we saw that at the conference over and over and over again. What happens when she loses her estrogen and progesterone? This. So that's why in this the Menopause Society, of course, they're very pro hormones and say, well, like let's help these women. Do you see any correlations there and any help that hormone therapy would be supportive of osteoarthritis?
Definitely, definitely. Obviously, looking at outcomes with and without hormone replacement is where you would start epidemiologically. But I just want to go back to nutrition and food and mention you highlight estrogen. There are lots of estrogenic substances in diet and the environment, some of which have are harmful effects, right? We know that some of the environmental estrogenic pollutants have negative health impacts. But we also know that some of the natural estrogen analogs in diet, estrogen-like molecules in the diet from soybean, from some of these very healthy diets, could also be adjunct, very useful components in the diet. So we need to go beyond just HRT and the patches, right? That's easy. But what about the diet? What about providing additional natural ways to boost estrogen levels through dietary intake? That's a great opportunity.
Mhm. Could you, how, the question then would be how much can we increase if we need to say a certain level of estrogen to protect our joints? I don't know what that is or what the research says, but then would eating enough tofu help us? Like, I want to know, like, how much tofu do I need to eat, more or less, in order to increase my levels to that? And assuming even post menopause, we have zero estrogen practically, can I get it enough with some of these foods, or is it just going to keep things in balance so that the inflammation is down?
Zoro, you asked the best questions. One of the things I want to highlight is that you could provide supplements and you could provide additional dietary intake. But what if, let me be devil's advocate here. What if the aging process is also influencing the receptors for these hormones on joint tissues? So we know that it's already happening. We know that as muscle, cartilage, ligament, tendon, spine tissues, as they get older, the receptors for growth factors, the receptors for anabolic mediators, and the receptors for some of the hormones are reduced in terms of abundance and number in the cells. So, in a way, it's nice to think that we can have a positive impact on health, but providing additional hormones or food derived analogs of these hormones through diet. But what if the receptors are not working well enough, right? What if they're not responsive anymore? What if there's some sort of blunting in the way that they signal? This is rarely discussed, and that's what we need to discuss. And that is where more research is needed to understand the concept of aging and how aging in musculoskeletal structures actually impairs the responsiveness of these tissues to anabolic factors and hormones. And that, I think, is the current challenge. We don't have enough research and we need to do more. But that's, I think, the really difficult part. We suspect that you could increase the levels of the hormones, but what if the tissues don't respond to them properly?
Exactly. That's why it's such a case by case thing. And like you did mention before, in terms of supplements, and this is a biohacking community as well. And we love to test, measure, and assess. And so I'm always saying, you know what? I don't care what the research says. If it works for you, fabulous. Or I don't care what the research says. It's not working for you. Just move on to find something else. And that's what I think is, it's so bio-individual. We all respond differently. We can look at research and say, okay, it's showing and promise, let's try it. Of course, weighing the benefits and risks and then see what happens. But some of these, in terms of hormones and hormone therapy and the osteoarthritis, I guess there's just not enough studies and it'll take a long time because we want to see outcomes over decades on does this really work or not. But I do want to ask you, because you are a leading expert in osteoarthritis, you've published over 400 scientific articles on the topic. Can you reverse osteoarthritis?
I would like to say I'm a glass half full person. I'm a very optimistic person, and I would like to say yes, but I don't know exactly what the solution is. Is it regenerative medicine or is it some sort of xenomorphic agent? So I think in order for us to reverse osteoarthritis, there needs to be some regenerative intervention. That could be stem cells, it could be PRP. We haven't discussed platelet-rich plasma. It's become very popular, and there's conflicting evidence in the literature. There's some papers that say it works and others that say don't work. And it all very much depends on which target population is being tested. If it's a young, athletic population versus older, much older, and chronic comorbidity type scenario. But I would imagine that in the future, we must aspire to reverse osteoarthritis, to reverse the back pain and the disc and spine degeneration issues, because we can't just focus on treating the symptoms. That's what the regulators want. The regulators want drugs and interventions that have a positive impact on pain and improve function of the joint, function of the spine. That's what they want. They also want reduced pharmacy dependency on polypharmacy, right? But we also need to see reversal of the symptoms and improvement of the structure. So I think pain is important. It's a higher priority. It's what we need to treat first. But then long term, we have an obligation as researchers and healthcare providers, especially if we're paid by taxpayers, if we are public servants, we have an obligation to think about regeneration of the tissues and reversal of the joint and of the joint changes. And so that's where I think regenerative medicine is so promising and so powerful, yet it hasn't had a great impact. We've been talking about regenerative medicine for 20 years. We've been talking about this enormous power of stem cells, but you inject stem cells into the joint, into the osteoarthritic joint. Most of the studies done so far suggest that within a few days, most of those cells are dead, cleared away. They actually have an immunomodulatory effect, but they don't home in on the degenerative part of the joint and regenerate it. That's what we sort of hoped and aspired 20 plus years ago. And the reality is that that doesn't happen. But nevertheless, I think multimodal and multidisciplinary approaches to osteoarthritis treatment and low back pain treatments must consider regeneration and reversal of those degenerative changes. Otherwise, we're not doing the patients and the public any favors by just treating their pain. As important as pain is, we also need to address the structure and regenerate joint tissues.
I love hearing that. And I never heard anyone except one person say, you can reverse this, or we are at least striving to. And that person introduced me to a drug called pentosan polysulfite. And this is a regenerative medicine doctor, Dr. Elizabeth Eworth from the Boulder Longevity Institute, just brilliant. And I never heard of this. And it's traditionally used to treat osteoarthritis in racehorses. You've probably heard of this. And it's been approved for managing chronic bladder issues, even though I didn't have any of that. And then there's some doctors who are using it off label to treat osteoarthritis in humans. And they're saying that there's improvements in pain and function, even the markers of cartilage metabolism. So, what are your thoughts on the potential of pentosan polysulfate as an off label therapy for reversing osteoarthritis in humans? And if there are other drugs out there like that?
Yeah, there are many drugs out there similar to that. And the moment you mention horses and equine species, I get excited because I view horses as a really good model. If something's been tried and tested in just mice and rats, somewhat more critical and more skeptical. But if it's been tested in companion animals that also have the same conditions as us, dogs, cats, and horses. I'm not talking about using them as research animals. I'm talking about them as patients. And if you take a group of arthritic horses, or if you take spontaneously occurring osteoarthritis in a beagle population of dogs and test them with these nutritional supplements, I think that is much more helpful than deriving information straight and or attempting to translate straight from a tiny rodent model all the way up to humans, right? We know in the US, the FDA has published the third iteration of the Modernization Act, meaning that there needs to be less reliance on animal models and more reliance on actual humans. So I would anticipate many of the future trials will focus on the human population
Mhm.
and will be using less of the animals and more of the, if you like, organ on chip, joint on chip systems, more of the mimetic in vitro models instead of very expensive, very complex, and potentially inhumane animal models. Now, of course, I've published with animal models too. I'm not against them. But the world is changing. The regulatory agencies are telling us we want to see better translation of scientific findings to humans. So use better translational models. And the horse and this polysulfate and several other treatments have been demonstrated to be quite effective in the horses. That gives me more confidence. And I think if you're discussing this with a group of patients, and we often do, the patients, the educated patients who listen to these stories about research and cutting edge innovations, they're going to be much more positive hearing that it's worked in a large animal model, in the horse, in the goat, even sheep are used in this context, rather than just jumping straight from rodents to humans. So I think one of the most promising areas is gene therapy, and that's been boosted massively post-COVID by all the technologies that are now established to develop viral gene therapy and even mRNA. There's several companies taking the same concept for the COVID vaccination to
Mhm.
take mRNA targets and simply inject them into the joint. And going back to your previous comment about reversing and regenerating the joint, that's where the real promise is. Taking drugs, all the small molecule drugs that were potentially pro-regenerative, pro-anabolic haven't worked. We've seen many of them fall out of these clinical trials recently. They're not being developed anymore. But the gene therapy and the next generation viral gene therapy and mRNA injection therapies could be the solution to reducing the pain, improving function, and rebuilding the cartilage and other joint tissue structures. That's, I think, the most exciting part. Nutrition is very important. It's an adjunct, right? But if you have very extensive joint damage and you need to regenerate it, nutrition but alone is not going to do anything. Supplements with curcumin and boswellia are not going to do a great deal. We need to target the gene and the pathways that are involved and boost real regeneration. And I think that's where research will focus in the next 5 to 7 years in pro-regenerative, pro-anabolic, and not just anti-inflammatory and pain treatments.
Yeah, that's why I had such hope. I still recommend people to go investigate Pentacin. I was an injectable. I know it's not fun to inject yourself, but she's had about 80% of the patients have pretty good results. I just was not one of them. And of course, this goes alongside all the diet, lifestyle, all the things that we should be doing. But it's the regeneration that, like you said, I just don't know if I could regenerate enough. How much collagen do I actually need to eat? The cartilage to regenerate. And that's what I think. So that drug itself is an anti-inflammatory, antibacterial, antiviral. It has like so many amazing properties. I was like, if this doesn't work, at least I'm getting a whole lot of other benefits from this. But I would love to see something. If when you're in so much pain, you're like, I'll just get over the injection, fine. Or you get someone to do it. But I would love to see some of that stuff. And like you said, the gene therapy is, yeah, it just sounds like a powerhouse. We'll see how that develops over the years. And again, more as the foundation. But I want to wrap up here. I have so many more questions. So we're going to have a part two, hopefully, if you agree to this.
Perfect.
So let's say there is a woman now listening who is been told she's got osteoarthritis. What are some of the practical tips and interventions for managing osteoarthritis, especially women who are going through this menopause transition? What can they do to help themselves feel better and be proactive today?
So, ladies, if you've recently been diagnosed with osteoarthritis or a spine OA that influences your low back pain, it's not a hopeless situation. There are solutions. Don't give up hope. Start with increasing your education on the topic. Start with all the non-pharmacological therapies that are being recommended for that condition. Keep an eye on your weight. Be as physically active as possible. One of my colleagues uses the terminology, motion is lotion for the joints. So get as active as possible. Even if there might be pain, you've got to make yourself go out and walk. Walking is actually one of the best therapeutics. The Osteoarthritis Action Alliance in Chapel Hill, North Carolina, is an organization that has the motto, walk with ease. And they also have the Spanish translation of this for the Spanish speaking world, which is promoting the benefits of walking and is crucially important to be as active as possible. Try supplements, try the different combinations, as Zora just mentioned earlier in this podcast. One of those is going to work for you. We're all different, and there's not going to be the one supplement that's going to work for everybody. So try these different things. If you get benefits from them, use them. Your condition can be managed. Your condition will be better controlled with better education, increased activity, weight management, and a positive outlook. And I think it's really important to get the positive messages out there. HRT is going to be potentially very beneficial for people with postmenopause, for both OA and osteoporosis. Vitamin D, exactly the same. Omega-3s, curcumin. Take these supplements, but most importantly, stay physically active, stay positively, mentally optimistic, and don't allow yourself to become anxious. And equip yourself with the best tools, the best education, and the best modern, up-to-date information for managing your condition. Self-care is the best thing we do day to day. Underneath self-care is self-management. And I have a very good friend in Australia. I'm going to mention her name, Joyce McSwan, who's developed the idea of self-healing. If you are well equipped with knowledge and you're looking after yourself, if the self-care standards are high, you're going to be able to self-manage your condition much better, and potentially self-healing is a real outcome of that. And self-healing is a new concept that she's developed, and maybe she can be one of your future guests to talk to your listeners about the power of self-healing and the power of augmented biology and how we can take advantage of some of the reparative and repair capabilities of our tissues and really self-heal.
Mm. I love that. I went to a Joe Dispenza workshop and he's so much, but I highly recommend that because he always says that your body and your mind is a pharmacy. Like you can heal so much through that. And I also recommend there's an app called Curable. I'm not no affiliation here, but I thought it's where I learned a lot about pain reprocessing therapy, managing pain, and it was brilliant. And the other thing, I'm not sure if you would recommend in terms of exercise, but I found that bicycling or cycling was easier for me on the joints. And I felt like, okay, that's some movement that I could do. And again, I think it's maybe perhaps do whatever you can, but move, right?
Absolutely. And of course, cycling and walking also significantly improve muscle function and muscle tone. And we know now that sarcopenia, gradual loss of muscle mass, and muscle function are important risk factors for developing osteoarthritis earlier. So we need to move. And if you can get on the bike and if you can get on the cycle machines in a gym, do that because they significantly improve your muscle function and your muscle mass and strength. And muscle strength is a really important new biomarker that's being used to establish. There's a thing that's called grip strength, and some people who have very poor grip strength, people who have this sarcopenic obesity, have reduced grip strength, and that's one of the biomarkers of sarcopenic related osteoarthritis and muscle loss, at least in a research context. So absolutely maintain physical activity, and if you can't run, if your jogging days are over, if your joints too painful, then you need to find other ways to maintain your muscle mass. And if that's through cycling, if that's through other forms, and swimming, certainly aquatic exercises, we didn't mention them earlier, are also very important in addition to land exercises. But everything that's related to movement is good, not just for the musculoskeletal system, but also for your mental health. And it's also fun if you get out there and do it with your friends, you're maintaining your social circles. And remember, isolation, doing things in isolation is not a good thing. So if you find a group of friends that have the same conditions, do it in a group and benefit from that group activity. And also it improves the social aspects of your life as well. And there are many, many people who have to live with these chronic musculoskeletal conditions, and they live alone and they live in isolation. And that is another of those risk factors that can potentially result in poor outcomes. So get out there and do the things that you love doing with your friends and do it in a social context. You will get greater benefits from it.
Oh, love this conversation. Thank you so much, Ali Mobasheri. I am so grateful for your work. The research that you do is unbelievable. I'm looking forward to hearing more about the gene therapy and the other medicine, or even the a holistic model we can also follow to lower our risk and perhaps one day reverse osteoarthritis. Thank you so much.
Thank you, Zora. I really enjoyed being a guest on your show, and thanks for the amazing work that you're doing on Hack My Age, and looking forward to our next discussion together.
Yay. And everyone who's been listening so far, thank you so much for reaching to the end of the podcast. And if you have questions, believe me, I know what you're feeling. Reach out to me and have a good day, good night, good morning, wherever you're at, and we'll see you next time.